Top Med Talk.
Today's Top Med Talk is a two-part piece. This is part 2, and part 1 has already been released. Please check out the show notes for more details.
Hundreds and thousands watching out there potentially, and we've already got some questions coming in on Slido. So, if I may, what would you see as the largest intraoperative impact on post-operative cognitive dysfunction? This is a recurring theme. We spend a lot of time talking about how to describe these things. What can we do to help?
Nothing. There is nothing intraoperative that will have significant impact. And maybe I sound very, I think the problem is we're spending so many resources on, should we do regional, should we do general, should we do this? If it has any impact, it is probably overwhelmed by everything else we can do pre and post-operative. We often focus on the 2 hours that patient is in the operating room and say, during the time that they're in the operating room, should we use this drug or that drug? Where honestly, there's many, many studies going on, but if you look at potential impact, if you're not even measuring what their pre-op cognitive function is, for example, you've already lost. So the fact that nobody is measuring preoperative cognitive function routinely, and yet we're all focused on let's use isoflurane and less of this and more of that. And there are so many more impacts we could have by putting those resources preoperatively and in delirium prevention post-op. So I'm not saying they don't have an impact, but if I had money to fund something, I think I would want to fund routine preoperative screening. I think you'd get the most bang for your buck with that.
My answer would be whatever we can do that would modify the surgical procedure such that there was less tissue disruption, less inflammatory cascade, etc., would probably where I'd put my money on the answer. I don't know that we have enough evidence in terms of the anesthetic options that we have to suggest that there is one that would be superior to the other. And maybe modifying the surgical procedure to say, maybe this patient doesn't benefit most from a surgical intervention. Let's explore alternatives, whether those are palliative, whether those are medical in nature. So that would be my answer.
So furious nodding there, because and Sarah, if you could comment, how are we getting better at no surgery being the right answer? Sarah, do you have a view on that?
Yeah, I do. It's not necessarily that no surgery is the best answer. Sometimes no surgery is the best answer. But sometimes if you are training for surgery, if you are making sure that the person who's going to be operated on is in their best condition for surgery before it begins, that they are adequately sleeping, exercising, have sufficient diet, if they are helped with caregivers so that they are oriented quickly after surgical procedures, so that they are like they're training for a sporting event. They're going in to something as best a condition as they possibly can be. If preoperative medications are dropped, if there's so many simple interventions that seem to be effective. It's not always no surgery, or sometimes it's other kinds of surgeries, right? Yeah. So there are so many tools in the toolbox here. We don't just have to say, let's divert frail patients out of the surgical arena.
No. And we're not trying to try that at all. My point is that each patient must be individualized. And if you haven't assessed frailty and cognitive function, the risk benefits cannot be, in the end, everyone says, well, who decides who has the surgery? The surgeon is at the end. It isn't. It's the patient. So make it seem like the anesthesia. Yes, exactly.
Radical thoughts there. So I'm going to interrupt because we have a bunch of questions lining up here, and I want to make sure we serve our audience well. Wonderful conversation. PeriopMed relies on so much on what we learned in the clinical sciences in med school. How do we address CRNA, that's nurse anaesthetist inclusion, given didactic and clinical education and training gaps. So I think the message we're getting, and this is very much the SPACI message, is everyone's in. Everyone who's involved needs to understand this thing. Is that right, Angela? Are you proactively including
Jeanna,
alternative ways?
I think Jeanna is now vice president. She will be president soon, so I'll let her comment in terms. I'm very proud of everything she's doing for the society and carrying it forward.
Oh, thank you. Well, that's all kudos to your mentorship. I so appreciate the fact that I have the chance to learn from you so directly. So to answer the audience's question, within SPACI, we have our Advanced Practice Provider Committee. And there are opportunities both to lead on that committee, to join the committee, where we have about every other month educational sessions that come up, and the committee comes together and we have one of us speak about a topic that is of interest that the committee votes for. So there are plenty of ways to, through SPACI, engage in that. We also have an overall discussion forum where questions are posed and all SPACI members interact together. So if there was a question that came up, whether it was CRNA, advanced practice provider, such as a nurse practitioner, a physician, a resident, you see answers from our SPACI community. So that would be the other way that we would address that. Hopefully that answers your question.
It does, and if I may interject, we collaborate on a perioperative medicine fellowship between Duke, UCL, and Southampton, where Mike Grocott is. And this year that's diversified to be a perioperative care fellowship as well, because it's perioperative care ultimately from that perspective. So if I may press on with the questions, the science seems mixed on what may cause delirium and what can be done to prevent delirium. What 2 to 3 post-stroke post-operative interventions should every anaesthetist consider? Now, you've already alluded to some of that, of which I'd say that the science being mixed. I think the unifying theory is inflammation every time I read about this. I think that the biology points to inflammation, whatever we mean by that, the whole time, and trying to mitigate the inflammatory process seems to be the greatest hope. So, Jeanna, do you want to start this time? We've got 2 to 3. You've mentioned some things already, tips to try and reduce delirium.
So if we're specifically speaking about the post-operative period, I would say standardization of delirium prevention order sets would be the heaviest hitter for me, ensuring that our patients are not getting deliriogenic sleep aids, but rather use of melatonin, good bowel regimen post-operatively, making sure that we're using a multimodal approach to analgesia, making sure that patients are oriented, and that we're actually screening them for post-operative delirium, that we have the presence of trained clinicians that know how to use a CAM ICU, or another delirium screening tool, training our clinicians that are on the floor managing these patients to screen them and identify delirium, even hypoactive cases, presence of family members, and education of family members for support. Those will be my 3 for post-operative care.
What a great list. Angela, anything to add to that?
I totally agree. The one thing I want to say is, I'll tell you what is holding us up is there are only a few floors that the nurses will know how to do delirium protocols post-op. I don't know, Jeanna, if that's your. So I think one of our biggest obstacles is if we identify these patients preoperatively, which we can, and in my talk, there's literature that show identifying them preoperatively does impact outcomes. I think the at-risk ones should have an order set for delirium prevention pathway, but if the nurses on the floors don't know how to do this, that's the biggest obstacle. And Jeanna, what are you seeing there in terms of the nurses actually being able to do this protocol if it's ordered?
One thing I want to touch on is at my former institute, an approach that we took that was actually rather successful was to train our physical therapists to be involved in the CAMS. Because we're often doing the mobility assessments, walking the patients, increasing mobility, which is of course important. And so we were able to extend the resources that we had in terms of who was available and was making regular contact with the patient in terms of delirium screening. So sometimes if we can't touch all registered nurses on all floors, sometimes staff such as physical therapists that make their rounds to other floors can be a way to approach that. To answer your question directly at Duke, we suffer from the same challenges that everyone does in terms of not necessarily having all floors have access to that training. But it's certainly something that's on our radar and that we're working towards.
Sarah?
I just want to say that our report is about 25 pages, but we try to boil down the recommendations that we've made for individuals, caregivers, healthcare providers, and hospitals into one page. So we have 3 one-page infographics designed for different audiences. They're available for free on the Global Council on Brain Health.org. And I encourage everybody to take a look at it. We've got them available in Spanish, French, Chinese, Arabic, and English.
Next question, if I may. Has anyone studied the potential role for preoperative cognitive training, stroke exercise in reducing POCD or more serious and catastrophic CNS deficits? And that's from Mark Koch. Training. So Sarah, have you heard much about training, whether it be, we've heard that physical training can make a difference, but also is there any brain training that people are talking about?
Yes. So all of the different lifestyle interventions that help support your brain health, including cognitive exercise. Now, I'm not talking about the brain games that are out there, but making sure that you are socially engaged, so that you're actually actively using your mind and exercising your brain like you would exercise your body. And we're talking about the interventions that have been well established. So if you're doing things like quitting smoking, improving your diet so that you're managing your cardiovascular risks, there are significant things that you can do preoperatively to put yourself in a much better position. And there's evidence out there to support its benefit.
And they're all anti-inflammatory as well, all those sorts of interventions. So it all biologically makes sense too.
Yeah, makes sense.
Angela?
Brain treatment. Yeah, no, I totally agree. I don't know of any, data, but part of the reason we don't have data is we don't usually even measure what the cognitive function is preoperatively. And what I want to just emphasize is this isn't just talking about patients with a diagnosis of dementia. When we studied this, what we found is 24% overall of patients over age 65 had unrecognized cognitive abnormalities and 40% over age 70. So I think it's important for the audience to realize that we're not just saying, somebody comes in, they have this diagnosis of dementia, you put them on a delirium prevention pathway. The reason cognitive evaluation is so important is in your 70-year-old patients, you are missing 40% of the time previously undiagnosed cognitive abnormality. So I think that's why this is just so huge. And that's why I would say that's where the opportunity. The other thing I'd love Sarah's input on is I get asked so many times by elderly patients, they're not as worried about mortality as they are about cognitive issues. They can't live at home. They can't live alone. They're not going to be mobile. And that's what I see is scaring them. We talk about cardiovascular mortality and things like that. What they're scared about is, will they be able to live alone after the surgery? And that's what I would love. Sarah, I don't know, does your report talk about that as well? That's so important to them?
Oh, absolutely. Absolutely. Because the reason that people care about their brain health is just for the point that you're speaking about, the ability to live independently, maintain their lives and their activities of daily living. It is a huge problem. And it is, even with successful surgical outcomes, the problems with cognition after surgery is significant.
Exactly right.
And
right.
So I couldn't agree with you more. And part of the recommendations that we're trying to do, and for people who live alone, this is a lot tougher, but to engage caregivers, be it friends or family, in their care so that they have somebody there to help them, or they're getting home health, at least, if they don't have access to friends and family that can help them transition more effectively to their life. But, a quick story is that one of our experts, as I mentioned, is Dan Blazer from Duke. He himself experienced delirium after a surgical intervention. And he and his colleagues didn't recognize it at the time for what it was. And it was only looking back at it and understanding what was going on perioperatively and postoperatively that they realized it. Now, this is a guy who's helped define what delirium is, right? It is widely underestimated. Angela, I love what your work is, because what it points to, and the unidentified cases that you're talking about when you've looked for them, is very supportive of this other notion that we have, is that people need to be assessed for their cognitive function, whether they're going into surgery or not, especially if they're going into surgery. And there's a mismatch there because people aren't talking to their doctors about their health, their brain health. And the preventative screenings are not happening. And so it's not surprising to me that you're finding this mismatch, because it's just not happening. So we're trying to encourage, as part of broader coalitions, that people get checkups so that you can see decline. Like, there's a baseline where people can be evaluated just like they would be for blood pressure, right? That their condition should be evaluated.
That's so you bring up an excellent point, which was important to us, that once we do this screening and we set this patient up for surgery, it's just as important as it is for the patient and the family to understand. We feel it's important that we make communication back to that patient's primary care provider or someone who has a longitudinal relationship with them for exactly the reason you're saying. It's not just enough for us to know in the period, but we need to have this either baseline or at least this assessment in this period of time so that patient can be tracked by someone who has that relationship with them. So I'm so glad you pointed that out.
So we're coming close to the end, and I know Sol's going to come back in and say hi in a second. But I want to do one question that's been up the whole time as we've been talking, from Peter in Bedford in the United Kingdom. Do you, and I presume by you he means you in the United States of America, have an equivalent of what we call here Choose Wisely, which is a national program, i.e. the requirement to talk about benefits, risks, alternative, and do nothing? It's probably something we got from you, but do you have the same scheme? Okay. Well, everyone should have it. It's good.
I don't know who got it from who, but we have Choose Wisely.
Okay.
I actually, as you probably know, Monty, I've been working with Rami, who I believe is the head of Choosing Wisely in the UK. And you honestly, one of the things that is great, I know it's in there, but we just don't do it. But what they have developed is a module to teach shared decision-making that we want to implement in the U.S. So I completely agree. We do have Choosing Wisely. It does say to do this, but nobody knows how. So we're hoping to work with Rami to see if, rather than recreating the wheel, we can work together to use that teaching module. So that's why I say we're learning from you on this.
And the Ramani is Professor Ramani Munasinger.
Yes. I'm sorry.
Sorry,
I'm
Jeanna.
sorry. I was also going to mention the resource that we have. I don't know if this is available outside of the U.S. is Prepare for Your Care, which comes in different languages and is free, and is a way, it's patient facing, and is a way for the patient to go online and have resources to start thinking about having this conversation before they arrive.
Great. Well, that's been a wonderful panel. I hope Sol can come back and join us in a second. But Sarah, final, where do we find your wonderful report, Sarah?
Yes, where? I want to go.
On the internet, I'm guessing. But
Global Council on Brain Health, all one word, www.globalcouncilonbrainhealth.org. And then look across the banner for delirium, because that's where all these resources are in the delirium section. We've recently published reports on women in brain health and music in brain health, but delirium was published right around the time of COVID. And of course, we're highly concerned about COVID because one of our largest recommendations is to engage caregivers in this process. And because of social distancing, we've got a lot of challenges with getting visitors who are not just visitors, but are actually adjunct care providers who are not able to access it. So it was published right around in March of 2020.
Great. Thank you very much indeed. Sol, can you join us for a final goodbye for this session?
Can you all see me? Hi there. Listen, as a spectator, bravo. What a wonderful session. Congratulations to everybody. As a co-host, I must say I'm delighted, proud, tickled that Sarah and Angela look like we've created this, collaborative effort going forward. So,
thanks, everyone. Goodbye. Wonderful. Take care.
Thank you so much.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.